Good afternoon, ladies and gentlemen, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press star 0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator, Ms. Jessie Checkley, Senior Improvement Lead at the Canadian Foundation for Healthcare Improvement. Please go ahead, Ms. Checkley.
Thank you, Val. Hello and welcome to today's on-call webinar entitled The Power of Partnership, Patients and Staff Co-Designing Bedside Care. As mentioned, I'm Jessie Checkley, a Senior Improvement Lead at the Canadian Foundation for Healthcare Improvement, and I'm pleased to be your host today. CFHI is a not-for-profit organization funded through an agreement with Health Canada. We work shoulder to shoulder with healthcare leaders to support implementing and enhancing healthcare improvements across provinces, territories, and regions. We're pleased to have more than 75 registrants for today's session. As I introduce our speakers, I'd ask that you please take a moment to introduce yourselves in the chat box, who you are, and where you're from. Joining us on today's call are Patricia O'Connor, Independent Consultant, CFHI Lead Faculty for Partnering with Patients and Families for Quality Improvement Collaborative, and Diane Gaffney from the Huron-Perth Healthcare Alliance. Diane is Project Lead for Bedside Transfer of Accountability, the Corporate Lead for Professional Practice at Huron-Perth. As well, we have Cathy Bachner, a Patient Partner with the Huron-Perth Healthcare Alliance. We'd like to take a minute to ensure that we're on the same page as, on today's call, we will be engaging leadership, frontline staff, patient partners in quality improvement, identify the key attributes of engagement-capable environments and the winning conditions for partnering with patients, examining leading practices to improve patient and family experience of care, including a case example on family presence and participation in care at bedside transfer of accountability, as well as whiteboard use, and measuring for success and support to support spread. Thank you for taking a minute to respond to our lobby questions. I see from your answers that we have a nice mix of folks joining us today from the following fields. We have researchers, healthcare administrators, clinicians and healthcare providers, quality advisors, patient partners, and folks who have identified themselves as other. If you want to take a minute and you did respond as other and you want to let us know which sector you're from, we would love to see that in our chat feature at the bottom right. We'd like to take a minute to ensure that we're on the same page as we talk about patient engagement. At CFHI, patient engagement is the involvement of patients and or family members in decision-making and active participation in a range of activities, for example, planning, evaluation, care, research, training, and recruitment. Starting from the premise of expertise by experience, patient engagement involves collaboration and partnership with professionals. And now I'm going to hand it over to Patty O'Connor. Patty, are you with us?
Yes, hi Jessie. Good afternoon, everyone. This framework that you see on this slide is for patient engagement, and it was developed by Christine Carmen and colleagues. This continuum of engagement helps us understand the ways in which patients and families can be meaningfully engaged and what that looks like, with the extent of engagement intensity increasing from left to right as you move across the continuum. So when you look horizontally across the slide, you see the continuum of engagement from consultation through involvement and finally partnership and shared decision-making, shared leadership and decision-making. The differentiating factor as you move from left to right is really the level of decision-making, authority, and control that patients and family members have in the process in co-designing work with those inside, direct care providers inside organizations. The vertical columns describe levels of engagement such as at the direct care level, at the organizational and governance level, and then in the blue line you see is for policy making. The squares at the far right indicate the results that may be seen when meaningful patient and family engagement takes place at these three levels. It's important to keep in mind that there is no one best way to engage patients, families, or caregivers, but the breadth of engagement at multiple levels clearly helps to strengthen what we refer to as an engagement-capable environment. Meaningful and effective patient engagement occurs when the trilogy of leadership support for patient and family-centered care is matched with clinical staff who are skilled in delivering person-centered care, and when patients and families are treated as partners in care and quality improvement, so at the direct care level as well as in co-design work. What's fundamental to the success of our patient and family engagement initiatives is the mindful attention we bring to establishing relationships. 4 years ago, at a policy dialogue session we held in Edmonton, Ross Baker and Jean-Louis Denis presented this diagram and suggested that patient engagement is potentially a powerful lever to align a system towards change and improvement. And Leslie Thompson, former CEO of Kingston General Hospital and now the CEO of Accreditation Canada, said that patient engagement is the most disruptive force in healthcare. If these statements are true, it's not because of one single entity on this diagram, but rather because of the three working together to make things better. This next slide lists 7 key attributes of engagement-capable environments. And the first really is about leadership. Courageous, cohesive leadership who walk the talk is critical. The CEO and senior leadership buy-in is essential for any improvement initiative that you're considering. It's also important to consider building infrastructure and processes and policies that can help sustain and support real patient partnerships over time. Second is recruitment of patient advisors with clear roles and responsibilities at all levels of decision-making. And here I'd like to just mention, if you aren't aware of the CFHI Patient Engagement Hub, which is on the website, and we have a slide later on that shows you the link for that. Is a how-to guide and has over 215 tools that could be very useful for you in your quality improvement work. The third key attribute is creation of mutual learning environments for patient advisors, staff, and physicians. And here we're really talking about targeting your frontline staff who are often overlooked to build their quality improvement competencies with patients and caregivers at the same time, so jointly learning that together. Fourth is coaching and facilitation support, and we list that because it's not obvious for frontline care providers to be having patients and family members engaged in co-design work. It does require someone taking a facilitation role and helping to guide that process until people start to feel more comfortable with it. Fifth is the continuous feedback loops and outcome measurement, including the use of smart technology. It's important to discuss results of patient experience or quality improvement measures with frontline staff to drive the next steps of change. Sixth are resources, in particular for startup funds to help begin new initiatives, and also in particular considering funds that may be needed to provide release time for that learning that you're going to do with frontline staff. And seventh are partnerships within and beyond your organization, in particular things like care transition partners, as more and more organizations are really tackling those transitions in care, and you can't do that alone. You really need to be working with your partners in primary care and in community services. This next slide shows a list of some evidence-informed patient engagement leading practices. I'm just going to go through them briefly, and then we're going to do some polling with you to get a sense of the degree to which you have any of these practices that are being rolled out across your organization at this time. So the first really refers to what I mentioned before, the Carmen framework, and that is engaging patients, families, or caregivers in direct and in all levels of decision-making within your organization. second is family presence and open visitation policies, and CFHI is currently running a collaborative that's free to support organizations who want to really improve their family presence policies. When CFHI did a study about a year and a half ago, they found that only 1 in 4 Canadian organizations really met the mark using the guidelines from the Institute for Patient and Family-Centered Care in terms of adequate family presence and visitation. Whiteboard use is well known by most organizations in Canada. That's a bedside tool for communication between families, patients, and the staff. Fourth is bedside transfer of accountability, and you're going to be hearing a case study of that today. Hourly intentional or comfort rounds, interprofessional bedside rounding, patient and family advisory councils, volunteer ambassador program, elder-friendly practices, joint interprofessional admission processes, and then within community care, chronic disease self-care management. And the last one on this particular list is written discharge information that includes information about the next appointment, medication times, and explanations about the medications, as well as a contact number for patients if they have questions. Now we're going to move to the polling question, and if you can just take a moment and tick in the box all of the practices that are currently in place in your organization. They don't have to necessarily be in place across all clinical areas, but if you have implemented them at least partly through your organization, please tick in the box so that we can get a sense of where people are. Okay, I'm not seeing much more in terms of additional changes in the boxes. So what we've got here, briefly in the profile, is not surprisingly the most common practice across your organizations is our patient and family advisory councils, or within Quebec they're also known as user committees or patient committees. So 62% of you have those in place. The next most frequent is our bedside whiteboards. Almost 44% of you have that operational inside your organizations. And then we have a number that are coming in at around a third. Written discharge information, 37%. That's really good, but then the inverse of that means that the vast majority of organizations do not provide that at this point in time. And we know that that's an important leading practice. Coming in at about a third of the organizations, we see things like chronic disease self-care management, elder-friendly practices. Those are the two that are coming in about 1/3 of you. And then family presence and open visitation, interestingly, it's 25%. So in some ways, you reflect exactly what the earlier poll that was done by CFHI shows, where it was 1 in 4. And then much smaller percentage of organizations who have hourly intentional rounding in place or joint interprofessional admission processes or volunteer admission ambassador program. Thank you so much for your comments there. It's helpful for us to get a brief environmental scan of where things are across Canada. I'm just waiting okay, there we go. Our intent at CFHI is to help you be intentional in identifying and supporting the winning conditions for connecting patient and family engagement with quality improvement. In our programming at CFHI, we have been very deliberate in supporting organizations who wish to build their capacity for quality improvement that includes patients as partners in co-designing health services. The various learning collaboratives that we lead now require patient partners as part of all the design teams. In July 2014, we launched a pan-Canadian collaborative called Partnering with Patients and Families for Quality Improvement. The collaborative goals were to build capacity and enhance organizational culture to partner with patients and families in order to improve quality across the healthcare continuum. 22 teams were selected from 6 provinces and 1 territory. It was a 17-month learning collaborative where CFHI provided funding of up to $50,000 to each organization. We ran 15 webinars and 1 in-person workshop, and there were 17 coaches who were assigned across the various teams. We had participants from primary care, from rehabilitation and continuing care, from acute care, adult and pediatric, and a mix of organizations who were both acute care and cancer agencies. Each team that was funded was required to have a basic core team that included an executive sponsor, a project lead, patient and family advisor, and a measurement lead. In terms of the improvements targeted by the 22 teams, almost all of the teams focused on improving patient experience of care, and 20 of the teams used this collaborative to build organizational and educational infrastructure to support patient partnerships. 1/3 of the teams took aim at coordination of care and transitions, such as admission and discharge processes. 1 team focused on first hospitalization, post-diagnosis of childhood cancer. Transfer of accountability was another focus. And chronic disease self-care management was a particular focus of our primary care teams and a dialysis center. Timely access to care was the focus of 3 teams. 2 teams introduced peer mentoring as an intervention to provide better support to patients and families, and 2 other teams used technology to improve care. And they included looking at transitions to adulthood for youth with complex conditions or cancer, and 1 dialysis center used technology to reduce the sense of isolation in their patients. Historically in healthcare, we have made huge assumptions about what is needed to improve the system. Our most serious blind spots have been believing that we know best what matters most to patients, families, and caregivers. It's time for us to listen, respond, and listen some more, and then take action. And now I'd like to introduce you to Cathy Bachner, who is a patient advisor at Huron-Perth Healthcare Alliance. She eloquently describes what her experiences were and helps us better understand what is important to patients and their family members. Over to you, Cathy.
Thank you, Patty and Jesse, and good morning to all of our webinar participants. Today we are addressing how patients and staff can be engaged as we lead change to improve the patient experience. As the wise Deepak Chopra states, there is no extra pieces. Everyone has a place to fill, and every piece must fit itself into the big jigsaw puzzle. Patients, family, and staff are picking up their own piece and mobilizing to collaborate and cooperate, co-creating an even better healthcare system. Please allow me to share some of my experience as a patient partner and the reasons I have for doing this important work. 2 weeks before Christmas, in December 2012, I became very sick. I was one of those patients who puzzled, perplexed, and was a challenging curiosity for 12 medical teams as they fought to save my life from the deadly necrotizing fasciitis infection or the flesh-eating disease. Doctors told me they have no idea how I survived the ordeal, and on the IC unit, they called me their Christmas miracle. The original 3-month battle took me through 4 hospitals offering various levels of care and rehabilitation. Subsequent to that, in my medical journey, I continue to see countless specialists, and I've had several more surgeries, procedures, and medical tests. I've observed and experienced a multitude of medical professionals and practices. So what? I've had an interesting medical experience, but what do I have any business or any patient partner have in co-designing healthcare? We're not schooled medical experts. Is there anything worthwhile we can bring to the table? Perhaps world-renowned healthcare professional and Oxford professor, Dr. Angela Coulter, one of the best and brightest in her field, having published over 300 research papers and several books on the patient experience, can give us a little insight. Her work centers on establishing patients and family members as healthcare co-produces the best healthcare system. Dr. Coulter indicates that when working with patients and families, it is important to recognize their assets, their strengths and abilities, not just their needs. She talks about the importance of equality between people and professionals, while blurring the boundaries between health, public health, community, and volunteer organizations. The results of this manner of working cooperatively and collaboratively provide solutions that are successfully designed and delivered with people, rather than to them or for them, with the motto, "Nothing about me without me." Patient partners will tell you it feels meaningful, purposeful, and positive to extend the knowledge and observations they've made during their healthcare experiences, to give their lived experience a voice, and to offer input on how to overcome obstacles and current pain points to build on the existing healthcare system. Their ideas are not very expensive or unrealistic, but when combined with the seasoned knowledge and work experience of the healthcare professionals, solutions and tangible outcomes can be the result, with the added benefit of improving staff satisfaction. It is wise for everyone to have a common platform of expectations when working with patient partners. Education and orientation of both the staff and the patient partner at the onset is vital to a positive and collaborative working arrangement. So perhaps I can share a message with you from the patient partners. Be not afraid. We do not want to stomp and scream and make unreasonable and expensive demands. We want to work with you. Please avoid tokenism. You can sit here, but you do not have anything of value to offer. Please let us explain our role of the committee and explain our role within it. Asia. Avoid speaking in acronyms. Enough said. Play to our individual strengths or experiences. We each have different experiences, perspectives, and skill sets that just might be an asset. Meetings must have a patient partner present. Use teleconferences as a good solution for busy schedules with tight timelines, or for remote, distant, or ailing and recovering patient partners. Promote equality by using first names only. The use of titles can lead to perceived elitism. Please provide meeting materials and include us on messages ahead of time, so we are not walking into the meeting blind. Then there should be a voting system for decision-making with equal weight for everyone. And finally, cover incurred expenses such as parking and mileage and childcare for your patient partners. But the most important thing of all is thank you for inviting us to the table and working collaboratively with us. Now, I will pass you over to Diane Gaffney. As mentioned before, she is the HPHA Corporate Lead Professional Practice, who will tell you about the Huron-Perth Healthcare Alliance's journey to patient-centered care and about our shared experience on the CFHI-supported research project to implement the nurses' transfer of accountability at Bedside. Thank you.
Thanks very much, Cathy. And Greetings to everyone. So glad that you're able to join us. I'm really happy that we're able to share with you the journey of our organization towards a more person-centered care and patient engagement. Just to tell you a little bit about our hospital, we're an alliance actually of 4 small community hospitals in southwestern Ontario, the largest of which is located in Stratford, Ontario, and we have a total of 193 beds. So our journey to person-centered care and patient engagement started, the largest initiative was probably in 2011. That was we were fortunate enough to partner with the Canadian Foundation for Healthcare Improvement on a patient engagement project, and this project was around the incorporation of patient partners in unit action councils throughout our alliance. This is a timeline of all of the kind of landmark initiatives that we've implemented in our organization. We don't have time, obviously, today to go into all of them, so I'm going to spend some time talking about our open visiting hours that we started in 2012, and a little bit about the bedside whiteboards, primarily as it relates to our bedside change of shift report or bedside transfer accountability, and that's where we'll spend the most of our time talking today. Our journey actually started in 2010 with the development of our Interprofessional Practice Council. We developed an interprofessional practice model in which patient and family-centered care was at the heart of the model. So because it was so pivotal to the success and our cultural transformation, we realized we needed to educate all of our staff and leaders and physicians about patient and family-centered care and engage them in discussions. So in 2011, I did a leadership workshop with all of the leaders of our organization, a 4-hour workshop on entitled Patient and Family-Centered Care Moving Beyond the Rhetoric, because like many organizations, we thought we were patient-centered, but when we looked and really started to examine what we were doing, we found that there was a lot lacking in how we were interacting with our patients and families. So in the second half of this 4-hour workshop, I actually brought in patients and family members to share their stories. And this was the first time that this had been done in our organization, that we actually had, as a group, sat down and listened to patients and families tell their stories. And it was the good, the bad, and the ugly. One of the family members told a story of really horrific experiences with our restrictive visiting hours throughout her husband's multiple inpatient admissions, and the impact that that had on her, or on her whole family, and in particular on the patient. This really lit a fire under our leadership team, and in particular our CEO, and he really, after that session, told me that he wanted to eliminate visiting hours immediately. Of course, we couldn't do it immediately. We had to follow a process. But that's what really got started. So I'll just spend a couple of minutes talking to you about that particular initiative. We were starting with very restrictive visiting hours that had been implemented during the time period of the SARS epidemic. And so really patients, you see the hours there on the team, very, very limited, or on the slide, I mean, very limited periods of time in which visitors were allowed to see their loved ones. The staff and the physicians loved these restricted visiting hours, and long after there was any kind of a need from an infection control perspective, we kept these hours in place. The patients and family members told us loud and clear that they didn't like them. You can see clearly if someone worked from a 12-hour shift from 8 a.m. to 8 p.m., they literally wouldn't be able to see their loved one in hospital. So we knew we had to make some changes. So why change? Well, of course, our culture change in the organization towards person and family-centered care and greater involvement of patients and family members in care and decision-making was a complete disconnect with these restrictive visiting hours. And we were having multiple complaints from patients and families on our discharge surveys and through community forums that were held. And all of that as well, but basically it comes down to this is just the right thing to do, that patients should have the right to determine who they want on their support team and the time of day that works best for them to see their friends and loved ones. So it also helps to encourage and support the involvement of the family and friends as part of that patient's care team and support team. It's important that they're engaged in the care and management of the patient and of course in accordance with the patient's wishes. By doing this, then they're much better able to support the patient when they've been discharged home if they've been a part of that care team throughout. So our process for doing this, we of course did a literature review and environmental scan. Back in 2011, 2012, there weren't a lot of hospitals that had done this, so there weren't a lot of examples that we could go to. We made presentations at all of the various forums that are listed there on the slide to get staff talking about it, expressing their concerns, looking at what some of the challenges might be, but also discussing, of course, the benefits. The challenges cited, and I think these are typical if you read any papers from organizations that have done this, that privacy and confidentiality is one of the first things that comes up. It'll interrupt the staff workflow. How are the patients going to get their rest? What about infection control if we have all of these visitors roaming the halls and going into rooms at all hours of the night? What about security concerns, and how will we get our breaks? And this particular one, it'll take longer for me to do my rounds if I have to talk to families. So that's where we were starting from, and keep that in mind then when we move forward and talk about the bedside change of shift report. So we developed person-centered visiting guidelines. So these are flexible visiting hours, basically 24/7, based on patient preference. They encourage dialogue between the patient, the family, and the healthcare providers around the patient care needs, including the presence and support of the patient and family members, and recognizes families as partners in care and the incredibly important role that they play in improving the quality of care. And when we speak about family, we're talking about not necessarily the biological family members. We're talking about anyone that patient determines or that tells us is an important part of their support team. Our statement of philosophy in visiting and family participation in care talks about the promotion and support of a patient-family-centered care model, and that families are partners in care and are respected as essential members of the healthcare team. And we do that in order to ensure not just patient satisfaction, but also the quality and safety of care. And we have another bullet there saying that basically it's the patient who defines who is their family and support team and how they will be involved in care planning and decision making. So to address this concern, because we didn't want to turn a deaf ear, of course, to the concerns that the staff and the physicians were raising, we included in our guidelines a couple of points. For example, the number of people welcomed at the bedside at any one time would be determined in collaboration with the patient and the family. Like many organizations, we have a minority of private rooms. Most of them are either double rooms or quad rooms. So we had to address that situation and basically said that it should be a negotiation between the patients and their families and the care providers as to how they would deal with the times that visitors were coming in. We also said that visiting could be interrupted to provide appropriate patient care and to protect the privacy of the patients, the other patients in the same room. We had an extensive implementation and communication plan. I won't go over all of these, but just internal communications with all of our various levels, right from the board through to frontline staff meetings. We did consult with University Health Network in Toronto. They had done a lot in terms of opening up their visiting hours. They didn't do it quite to the same extent that we did, but they were very helpful in helping to guide us. We put articles in our staff newsletter, which is called Insights, and lots of email communications. We also communicated with family physician offices, with the clergy who would be coming into the hospital on a regular basis, just so that the whole community was aware of what we were doing. So the lessons that we learned from this, we certainly found that it was incredibly beneficial, that this initiative was very tightly aligned with our organization's strategic directions and priorities. I think that's essential, and we had buy-in from the senior leadership team from the beginning, so that's really important. The education on person-centered care, while we were doing this, we were also doing our patient engagement project, and we were doing, there was a 4-hour mandatory workshop for all staff who were involved in patient care on interprofessional collaborative practice, but also patient and family-centered care. And in those workshops, we had a lot of discussion around family presence and participation in care. So that was very pivotal in helping to move the staff forward in particular. A thorough stakeholder analysis. We thought that we communicated with everybody, that we had discussions with everybody, and getting fairly close to our implementation date, we realized that we hadn't connected with security and facilities management, which is pretty important if you're having people coming during the hours where your facility is normally locked. So we were able to scramble and make sure that we had all of those considerations included. We really felt it was important that all patient carriers needed to be included, no exceptions. So that really crossed over all of our care experiences. So whether it was an ambulatory experience in the emerge department, that family would be welcome to participate in care, through all of our inpatient departments as well. If the patient has a pre-admit appointment, we do have a discussion that's documented in their health record at that time around their preferences for their family's participation. Communicate, communicate, and then communicate. It's just as with all initiatives, I think. It's often, it is the key to success, and it's probably the #1 area where we fall down if it's not done properly. What we found was that with increased exposure that staff had to having family present and involved in care, it really increased their comfort level in working together with the patients and families. And that in turn then led to for increased partnerships between staff, physicians, and patients and families throughout all aspects of the organization, and we're continuing to grow that. I wanted to do a little deeper dive with you on our bedside transfer of accountability, or another name for it is bedside change of shift report. This is a title slide from a presentation that Cathy and myself and Donnaline Terhodes, our Chief Nursing Executive and Program Director for Surgery. We did this at the Institute for Patient and Family-Centered Care this past July. So this project, we had a wonderful team working with us. Cathy was involved as our patient partner lead, and as well we had a family member as well. We had leaders from both of our 2 pilot units, and I'll explain what those units were in a minute. We had our executive sponsor, who was our Vice President of Partnerships and Patient Experience. We had frontline staff working on the project team. Patty O'Connor, who you just heard from, we were fortunate enough to have her as our faculty advisor. And again, this was one of the learning collaborative projects that Patty was describing earlier. We showed this picture of the project team because you can see that one of our project team members, that's Jane, is joining us remotely by video conference. And I think Cathy Bachner had mentioned during her talk that you have to use technology to really help engage everyone when you have distances, and time is an important factor. So we did a lot of video conferencing because our 2 pilot sites were geographically distant from each other. So we really, from the inception of this project, had meaningful patient partner engagement at every stage. Cathy Bachner actually worked with me on the funding application to the Canadian Foundation for Healthcare Improvement. So from the very inception of the idea, we had Cathy working alongside with us. We had her on the project team, as well as Barb, who was our family member. We had them, both Cathy and Barb, very much in our staff education sessions. We engaged patients, of course, on the unit, who were on the unit in the evaluation of what we were doing, and we engaged patients actually right at the point of bedside transfer of accountability. So really very much crossing over the whole spectrum of the project. Why we were doing this was that we recognized that we had a real issue in our organization with transfer of accountability at shift change, and that it wasn't occurring in any kind of standardized way. So therefore there were a lot of variations in the quality and methodology of that change of shift report. And it also, of course, was not occurring at the bedside, anywhere else but the bedside. So there was no engagement of patients and families in the process. And why is that an issue? Well, we certainly recognize, and the literature, this is just one quote from the Joint Commission in the States, but we know that 80% of serious medical errors involve miscommunication between care providers when patients are transferred or handed off. We were certainly not the first people to implement this. There are lots of studies in the literature, a number of wonderful studies from St. Michael's Hospital in Toronto that we looked to help us design this process. But certainly there are benefits of increased patient safety with bedside TOA, increased patient satisfaction, and increased staff satisfaction. And that was a little bit of a tough sell at first when we were doing the education sessions with the staff, but we were able to report, and I'll show you some information that shows that the staff, we certainly experienced that as well. The nurses, when we started talking about this, of course, had concerns, and once again, patient confidentiality was one of the first things that gets brought up when we talk about this. They were also concerned about repetitive work, that they could find this information that was already documented in the electronic health record. They thought it would take too much time if they had to do this. And what about the isolation patients? They would take even longer because you had to don and doff all of the protective apparel. And then what if the next shift doesn't show up on time? So these are some of the things that our nurses told us and certainly were reported in the literature as very common nursing concerns. So we developed some aim statements to help focus our project. We, of course, wanted to improve patient safety through decrease in errors such as medication errors and adverse events. We wanted to enhance patient satisfaction through that personal introduction of the next nurse at the change of shift, and the engagement in the information exchange between the nurses. And also, it was absolutely an aim of our project to improve the nurses' ability to prioritize their care for their patients on their assignment that day through having access to greater amounts of information and quality of information about their patients at the very beginning of their shift. We had 2 pilot sites, as I mentioned earlier, the St. Mary's Hospital, which is about 25 minutes away from our Stratford General site. It's a 20-bed unit with 10 acute medicine beds and 10 complex continuing care beds. And then the surgery unit here at Stratford General Hospital, a 32-bed unit with 25 surgery beds and 7 complex continuing care beds. As I mentioned, we had staff education sessions that were mandatory for the staff on these units, for all the RNs and RPNs. We talked about what the literature told us about bedside TOA, the benefits and the challenges. And then we introduced a tool that for formatting that whole discussion at the bedside based on the SBAR format, and I'll show you that in the next slide. We included practice scenarios and simulation exercises for the latter part of the last half of the 2-hour session, and that was incredibly important. And we had our patient partners included in those sessions, and in particular in the simulation sessions as well. Here is the tool. I believe it's part of the resources that you get with this webinar, so I won't go through it point by any means, but SBAR, for those of you that aren't familiar with it, is a tool. It's a structured way for conversations that nurses have with other care professionals, and it could be nurses or physicians or any other members of the team. So we had to make this fit into a bedside transfer of accountability scenario. So all of this was done by the project team, and it went through many different iterations as we were testing it out during the pilot study. One of the things that you'll note there in the situation section, which is the very first part of the discussion, is updating the whiteboard. We had implemented bedside whiteboards a number of years earlier, but we were having very inconsistent use. Sometimes it had fallen off completely, that they weren't being utilized at all. So we used this as a chance to really hardwire the updating of the whiteboard into the whole procedure for the change of shift report. And that's been very successful on these 2 units. This is a pamphlet. We realized we had to also educate the patients on our units with respect to this process because this was new to them. So Cathy Bachner, who we've heard from this morning, also was very, very pivotal in doing this. Cathy is a teacher by profession with over 30 years of experience as a grade 8 teacher, and Cathy really took the lead on developing this brochure. And one of the features that we particularly liked about this, that she encouraged us to include, was having a section for the patients to be able to write down the points that they needed to discuss with their care team. So one section for things that they wanted to discuss with the nurse, and another section for things that they would discuss with their physician. Because often, as we know, when patients are tired, not feeling well, and that's when the people are coming in to do rounds, that they forget what it is that they want to discuss. So this would help to support them. With respect to the confidentiality concerns, we've included some information here just because this is the way in which we responded to the concerns, because this is certainly the #1 concern that nurses expressed. So we let them know that the patients have control over whether or not bedside TOA happens. At the beginning of the patient's stay, the patient's given the information pamphlet about it, and they're asked about their preferences, and then the whole process is explained to them. And then at the beginning of each change of shift report at the bedside, the patients are asked if they would like to have this occur at the bedside, because their preferences, of course, can change from one day to the next. So they have that control at every change of shift. And as well, if there's any information and sensitive issues that they'd like to keep private. The patient identifies who their significant others are and who they would like to participate in this exchange and who they would prefer doesn't participate. We close the curtains, of course, in semi-private and ward rooms to try to keep it as private as possible and have the nurses speak in a voice loud enough to be heard by the patient and the family, but try to keep it so that it's not overheard by everyone else. But we all know that that's the reality and the limitation of semi-private and ward rooms. We also let them know that the College of Nurses of Ontario does support the exchange of information at the bedside, but expects the nurses to use their professional judgment with respect to sensitive information. Patty O'Connor as our advisor for the study. This is one of the many gems that she gave us. Was the suggestion to use a plan, do, study, act cycle when implementing this. So when we started the implementation, we only started with 2 nurses at a time at a change of shift, and we worked through the procedures with those 2 nurses at each change of shift to really test out our procedures and make any adjustments that we needed to that or this SBAR quick reference tool that we had. We were able to measure the time that it was taking, and our goal was to make sure that the time wasn't any longer than that which they were doing before implementing bedside TOA. We were able to get in-the-moment feedback from staff and patients, and that really helped us to do all that fine-tuning so that we felt confident when we were rolling it out with the rest of the staff. We had a fairly extensive evaluation plan. I can't go into all of the various tools that we used to evaluate. We did use a mixture of quantitative and qualitative approaches. Qualitative was mostly the in-the-moment feedback from patients and families and staff, but also focus groups that were held at the beginning and end of the study. We had 3 data collection periods. At the baseline, which occurred a month prior to bedside TOA, we refer to that as T1. T2, about 4 months into the implementation, and then T3 was the final implementation, 8 months after implementing. We had a tremendous amount of data. We were very satisfied with the outcomes it showed. It really taught us a lot about the process and certainly showed the benefits. Just going to share with you a couple of the results. This is with respect to patient satisfaction. We used the Canadian Patient Experiences Survey, and this shows the care from nurses subscale. And what we saw that there was an initial drop, albeit non-statistically significant, from T1 to T2, but then we saw a significant increase from T2 to T3. And we believe that's because in the initial stages of implementation, it wasn't always consistent, and we weren't always having the bedside report done with the patients at the bedside. So it took a little while to get this hardwired into practice, but we certainly saw by the 8-month point that it seemed to be patients were very much scored higher on this care from the nurses subscale. And we saw a similar thing with the staff when we used the global measure of work satisfaction, and we found that there was an initial dip in work satisfaction, which is very common when you're implementing this kind of a change, because it is a significant change to nursing practice. But we're very happy to see a statistically significant increase from T2 to T3, and this, we believe, coincides with nurses really starting to realize the benefits to them as well as their patients. We were also, of course, measured the time required. We used this as a runtime metric. It was measured every single shift throughout the first 4 months, and then we did more sporadic evaluations after that. But we were able to, in 4 months, it actually showed a reduction of 4 minutes in the total time required for change of shift. So just a couple of slides. I'm not going to read all of these off to you, but just to let you know what the patients were telling us about bedside transfer accountability. That it was helpful to be included. It was a good idea. I had previous surgery here, and this didn't happen. It relieves my concerns that I'm being well looked after, and there's comfort knowing that everyone is on the same page. Interestingly, all the feedback that we got from patients with respect to confidentiality concerns was that it wasn't a concern from them. So this one quote says, "There's no issues with confidentiality. It depends on the sensitivity, what it depends on the patient and the situation. Discussed often already with other patients in the room, so there's really no issue." So what were the staff telling us? They said it was good that we're getting to know the patient's assignment early. It's a quick look. I feel safer when I see my patients right away at the beginning of the shift because I know which ones will be safe while I look after the others. And I like meeting the patients and eyeballing at the start of shift. It helps me to prioritize my care. So our lessons learned, Certainly, the inclusion of patients and family members and staff in all aspects of the project from the beginning was, I think, very pivotal to the success of this project. The communication of those daily metrics, so the time required and the comments coming back from patients and family members and staff were shared daily on their huddle boards. We had visible senior leadership support. Actually, our vice president, who is our sponsor for this project, took her turns doing the observations and supporting staff at change of shift, as did all members of the project team. Including role-playing, very important, that the staff develop a comfort level during the education sessions, and wherever possible, including the patients and family members in that is really valuable. The staff thoroughly enjoyed that. The daily observations by leaders, especially during that first 3 to 4 months, very important. Using plan, do, study, act cycles to fine-tune your processes, and also reinforcing the use of the whiteboards. It's a package, and we try to impress that upon the staff, that it's really a whole package. Actively listening to the staff concerns and responding. They need to know that we're not sloughing off their concerns. We appreciate them, we understand them, and that we responded with ways to mitigate those concerns. And then lastly, that sustaining practice change is difficult. We really found that what it took to embed this in practice as a practice expectation was the leaders, team leaders and managers on the units daily rounding on patients to ask them about their involvement and how they valued that, and then following up with staff for patients that hadn't had that bedside transfer of accountability that day in the moment, so that they realized this was a practice expectation. So just to end off with my portion here of the presentation, leading change is very difficult, and it can be very, very rewarding, but I thought this is a cartoon that really depicts the experience. People often do recognize across all levels that we do need to change, but when you ask who wants to change, the hands go down, and then when you ask who wants to lead the change, the room clears. So kudos to all of you that are leading some of these very challenging change initiatives to advance patient engagements and patient-centered care, and hang in there. The rewards are well worth it.
Thank you so much, Diane, as well to Cathy and Patty. At this time, we've asked for your questions if you have any from any of our presenters, but as we wait for your questions, we'll actually advance and sort of put a thought out there for you. We'd like to hear from you if you would prefer to answer this instead, about how you see yourself moving forward on your journey into partnering with patients and families. So I'll leave that open for a couple of minutes on the chat and ask you to add your comments to the chat on the bottom right of your screen. I see that we've got a couple of comments coming in, and I'll wait for those to come in and we'll address them. In the meantime, just to let everyone know, as mentioned by Patty previously, one of the other outcomes of this collaborative and previous CFHI programming was the creation of an extensive patient engagement resource hub. There's a wealth of information about resources that can help you in your patient partnership journey on the Patient Engagement Resource Hub, and we encourage you to check, to go to the website, because it's a great opportunity to learn from others. There are resources and tools, both Canadian and international, that can help you as you move forward in your journey. So I see that we have a comment from R. Edwards. If the change is so beneficial to patients, why the resistance from staff? Seems as if patients and staff are at odds rather than a team, despite all the rhetoric. Diane, can I pass that to you and to Cathy?
Yes, yeah, absolutely. So I'll maybe start and then Cathy can chime in. It's a good question, and I think the staff, if you ask them, they would say that yes, it's all a team, but they become, I think with workload, they're so used to doing things in a certain way that they resist most changes, I think, that we try to implement. And it takes a while for them to see, again, the benefits. So they have to really live it to see how appreciative the patients and families are, and also to see the benefits that's to their own practice. So I think it takes some time, but that's been our experience anyway. What do you think, Cathy?
I do think that this is where patient stories come in to make a really big impact. If I shared the story with any of the staff, even some that were a little perhaps standoffish, when they got to hear the story and the importance of their voice talking with me and how that impacted me and my care, sometimes they even shed a tear. So they did transition, but it does take communication, and it does take time, and it takes patience, but it really sincerely is worth that effort.
Thank you both. I had a comment from Ioana. Congrats for your results, and she's wondering if you're aware of other organizations who have seen similar results for the two initiatives.
Yes, I mentioned St. Michael's Hospital, and Leanne Jeffs and her team there have written a number of papers on this, and really saw very similar results to what we saw. So St. Michael's, I think, is a great resource. And with respect to visiting hours, there are many hospitals now. We were fairly early, but certainly would look to Kingston and Kingston General Hospital, Thunder Bay. There's a number of hospitals, and that's been, of course, part of the e-collaborative that Canadian Foundation for Healthcare Improvement is doing now. Is that family presence and participation in care. So I think you're just going to see it continue to grow.
Thanks, Diane. We also have a comment from Estelle from the CIS de l'Outaouais, and she's actually mentioning that she is part of a team that's part of the Better Together e-collaborative that's going on right now around family presence and families as partners in care. And this is their first step in partnering with patients and families with their healthcare leaders in their organization. So they're working hard, and they're making their way down their journey of partnering with patients. I'll give one more minute for any comments that folks might have, and then we'll move into our wrap-up. See, last comment from our Edwards, that in his or her experience with visiting hours, they felt resistance from the physicians especially, and they're asking quickly what your approach was in engaging physicians.
I would have to say our physicians here, there was some resistance. It was mostly the nursing staff that were more concerned about it. With the physicians, we engaged them in the beginning just through conversations, through education sessions with the physicians, and it was interesting. On the very first day, I'll just share this very quick story with you. The very first day that we went live, it was October the 15th, 2012. And one of the physicians who had been very resistant was on the surgery unit to see some of his patients, and our program director for surgery happened to be there, and he came up to her and said, "Now I get it. Now I see what it's about." There were two little boys that came hand in hand at about 7:30 in the morning to come and see their mother before they went for their school day, and the difference that made to those children and to the mother. He saw that right away and understood just at a glance, okay, now I get it, and now I see what difference that's made to my patients. So I think that this is how they might express some hesitancy. You try and work with them and work through it, but then when they actually have that lived experience with it, they see the benefit to their patients, they're on board. It's not an issue for us at all anymore. It's never discussed. It's just the way we do, the way we work with our families.
Thanks so much. I'm just going to go through our next slides very quickly to let everyone know that there is a list of resources and references that are part of this presentation, and all of the PowerPoint resources and tools discussed in the webinar will be made available on the CFHI website, and you'll be sent a message related to that. So on our upcoming webinars, you'll see on our screen that we've got a bit of our fall lineup upcoming for October. And what I'd like to do now is quickly ask folks to do a quick poll to tell us how we did on today's call. And while you're answering those questions, I'd really like to thank you for joining us on today's on-call, as well as our presenters, Patty O'Connor, Diane Gaffney, and Cathy Bachner, for sharing their experience and expertise in their work in partnering with patients and families from both a provider perspective as well as from a patient partner perspective. So I think folks are already answering the questions, but I'll read them out quickly. We hope to understand better, has this webinar increased your knowledge of evidence-based leading practices to improve patient and family experience of care? Has the webinar enhanced your understanding of how to engage leadership, frontline staff, and patient partners in quality improvement and change management activities? Have you learned something new about what your organization can do to evaluate results and measure for success? And more questions about your satisfaction with the webinar, your ability to apply what you learned from the webinar, and any other comments that you have for us to allow us to better improve what we do as we move forward. Thank you so much. This ends today's webinar.
This concludes today's call. Thank you for your participation. You may now disconnect.